Welcome back. Moving on with our schedule, we have the second symposium of the academic sessions, Advances in Cardiology, Beating the Beat. I cordially invite the co-chairpersons, Dr. P.P. Sadanandan, Consultant Cardiologist, Teaching Hospital Karapitiya, and Dr. Arosha Disanayaka, Senior Lecturer in Medicine, Faculty of Medicine, University of Ruhuna, to chair the session.
Thank you very much. Good morning to both the panelists as well as the attendees. Welcome to the Symposium on Cardiology. Advances in Cardiology, Beating the Beat. That's our theme. And for this session, we have three very eminent speakers. We have Dr. Kirti Divulweber, who is a consultant cardiac electrophysiologist, Dr. Vajira Senaratna, consultant cardiologist, and Dr. W.S. Sansaraj, consultant cardiologist. I just wish to remind you that questions will be entertained at the end of all three presentations. And also the audience, those in the audience need to type in their questions in the Q&A box of this platform. If by any chance you cannot access the Q&A box, please raise your hand, unmute, and talk. Now that will happen at the end of all three presentations. And then we will start off with Dr. Kirti Divulweber, the first speaker. He is the consultant cardiac electrophysiologist attached to Teaching Hospital Coronary. And he will be speaking to us on arrhythmias in young adults. Over to you, Dr. Divulweber.
Very good morning to you all. It's a pleasure for me to deliver this lecture on this historic Galle Medical Association annual academic sessions. And I should thank the president of the Galle Medical Association and Sri Lankan College of Cardiology for giving me this opportunity. Without further ado, I'll start my presentation. The topic at hand is to discuss about arrhythmias in young adults. Sorry. The WHO definitions about young adult means that anyone who falls between age of 20 to 40 is considered as young adult. However, that we know that legal age of adulthood start at age of 18. Despite having witnessed a significant development in the diagnosis and management of all kinds of arrhythmias, but there are significant deficiency of epidemiology and surveillances regarding rhythm issues. So in brief, as we know, the heart is a muscular pump which has a very sophisticated electrical wiring. And if you classify arrhythmia, you could basically classify them into broad arms. The other end is bradycardia. The other extreme end is tachycardia. If you take arrhythmia in young adults, you would find that they are not a uniform group. They are a heterogeneous cohort. On one end, we have a set of people who have arrhythmia in the presence of a structurally normal heart. And we could find people who have either congenital heart disease or acquired structural abnormalities presenting with arrhythmias. And then we have inherited arrhythmia syndromes. And occasionally we find people who present with heart rhythm issues, but obviously their heart is either electrically or structurally normal, but the rhythm is resulted from external factors. So there are very many ways that people who present with arrhythmia to us. This is not very specific for young adults, but given the spectrum, you would find people presented with palpitation, either transient or sustained. They come with syncope, they come with features of heart failure, and sometimes if the acute presentation could be with multi-organ failure. And most tragically, people can die of all these arrhythmias out of hospital. Cardiac arrest is one of the big issues. And very rarely we come across people, they are not straightforward in its way of presentation. They come as fits, they come at following road traffic accidents, and drowning could be resulted as having an arrhythmia or as falls or strokes. So why do we need to take these matters seriously? Because we know that young adults being a workforce of the country, and they need to be on their feet and deliver their maximum, and arrhythmia can get on the way. And as we know that arrhythmia, in my understanding, that's how I feel, it brings agony, it brings misery, and it brings tragedy. So we need to take arrhythmia more seriously, because we know that sometimes arrhythmia could be a manifestation of an underlying structural heart disease. It could lead to decompensation of a stable heart disease, and it could lead to sudden tragic deaths. And if we take this issue a bit further, arrhythmia runs in families, and arrhythmia has implications during pregnancies and being young adults, sports participation, and involved in recreational activities. Arrhythmia has some implications. So these things we know. So if you take common arrhythmias, in your practice, you are more likely to encounter people having sinus tachycardias. Atrioventricular and aortic reentry tachycardia are common as well. And you might come across WPW syndrome and various tachycardias that can associate with WPW syndrome. And in this part of the world, prebacterial ventricular complexes are very common, especially when they come from outflow tracts of the heart. Reflex syncope is not necessarily arrhythmia per se, but it's actually causing heart rhythm issue due to vagal activation coming down from the brain. And if you take SVTs, supraventricular tachycardias, you could appreciate the age, especially in young people. AVNRTs is relatively common as compared to AVNR, accessory pathway tachycardia or tachyarrhythmias. So SVTs can either present with narrow complex or wide complexes, both morphologies. Sometimes, mostly it is 80% of the time, it's going to be a narrow complex tachycardia. And WPW syndrome, as I mentioned earlier, they can have various ways of presenting. They might come with an incidental defection of having pre-excited in the ECD. They might present with a narrow complex tachycardia or broad complex tachycardia or even pre-excited tachycardia. Atrial fibrillation is relatively uncommon in younger people, but however, they can present in the presence of having after a pinch of alcohol. And as we know, obesity and obstructive sleep apnea is now prevalent in the younger people. And atrial fibrillation could be the first presentation, and rarely concealed accessory pathways or structural abnormality can cause atrial fibrillation. The PVCs are very common, and it's not unusual that if you come across one or two PVCs, if you do an ECG. What is the important thing about PVC, that it could most of the time they could be idiopathic, that you wouldn't find anything unusual in their hearts. However, it's important that they will require a thorough assessment of that includes Holter monitoring and imaging in order to make sure that they don't have anything underlying. And however, the long-term data suggests that the PVC increase the mortality. Outflow tract PVCs are the commonest. This is a ECG of a person who has RVOT type of ventricular PVCs. And occasionally PVCs can organize into ventricular tachycardia. So when we come across a PVC, what we do is we try to build up a symptom ECG correlation, and when we do a ambulatory ECG in order to assess the number of PVC to quantify them and take at a percentage, and whether we see whether they develop ventricular tachyarrhythmias, have they got any other abnormal rhythms, and we make sure that they will have either at least an echocardiogram to assess the cardiac structure, because sometimes PVC can cause troubles. If the PVC burden is high, it can lead to LV dysfunction, or sometimes PVC could be a manifestation of subtle underlying cardiac issues. Rarely, PVC can cause sudden cardiac death. And the reason I wanted to highlight PVC is they are actually treatable, and the catheter ablation has excellent results if it comes to a point that the treatment is required. Bradyarrhythmias, what we have to remember, there are various types of bradyarrhythmias, basically sinus bradyarrhythmias and heart blocks. They are relatively rare. Pathological bradyarrhythmias are relatively rare in young people. However, if we come across a person with bradyarrhythmia, we need to assess their symptom, depends on the functional status. They might have, because the bradyarrhythmia lead to tissue underperfusion, they develop weakness and they complaints of exercise intolerance. They might have a single episode at rest or during exertion. Sinus bradycardia, remember that it's not equivalent to sick sinus syndrome. We know that in young people, they tend to have bradyarrhythmia, especially during nights, and make sure that obstructive sleep apnea can cause bradyarrhythmia during nights. And reflex physiology is common, and after a common faint, if you do an ECG immediately after, you would find they can have various kind of bradyarrhythmias. So PR prolongation and Ventricular phenomenon is common in young people, especially during sleep. So the point is that intrinsic bradycardias or bradycardia due to intrinsic conduction tissue disorder is uncommon in young people. So we have to exclude a secondary causes. So it's important that we need to build symptom ECG correlation. They might require long-term monitoring, and it's important to assess the coronary competence with exercise ECG. We have to make sure that there's no underlying causes or endocrine causes that can cause bradycardia, and we need to assess them with imaging in order to make sure how is the LV function, is there any structural abnormality, and if you suspect reflex or neurocardio inhibitor or common faint, might have to want to do a tilt table test as well. Heart blocks generally rare in young people. However, it associated with congenital heart disease from the disease itself or as a result of receiving some sort of surgical treatment. And it's important if you come across people with complete heart block in young people, what we have to remember that it carries a poor prognosis. So people can die suddenly from having ventricular standstill, or very rarely we have come across people develop ventricular fibrillation due to extreme bradycardia. And if a person lives on extreme bradycardia, it leads to LV dilatation and eventual LV dysfunction and pump failure. So we have to take complete heart block serious in young people. So we discussed this, and it's important that we assess this patient, make sure that symptom ECG correlation can build up and we can prove that this ECG is responsible for their symptoms. In order to do that, we might have to do an ambulatory ECG. An implantable loop recorder is a small stick that acts like a monitor, which can record a continuous heart rhythm for 2-3 years. Which is a simple device which can go underneath the skin. Also, we have to arrange 2D echo, cardiac MRI, and depends on the risk history, we might want to do a tilt table test or exercise ECG. Only very rarely we require an EP study. So the point that I need to highlight is if a patient is having sinus node disease, pacing will only improve the quality of life. But when you have a heart block, the pacing will improve the quality of life and prognosis. So we have witnessed a significant development of device therapy for heart rhythm abnormalities. This umbrella term, cardiac electronic implantable devices. So we can offer endocardial pacing, we can offer epicardial pacing, we have cardiac resynchronization for patients with heart failure, we have novel pacing techniques, leadless pacemakers, we can pace the conduction system, and when it's come to tachycardia therapy, you must have heard this implantable cardioverter defibrillator. They are capable of giving shocks. Now we have subcutaneous ICD, and from the diagnostic front, we have implantable loop recorder. We have telemetry and remote monitoring as well. And remember that in certain situations, we could offer catheter ablation for certain type of bradyarrhythmia. This is something we haven't even thought of. Now, obviously, we could cauterize the neuronal ganglions inside the heart, and thereby cutting off the antivagal stimulation to the heart, and we might be able to cure reflex syncope, certain AV nodal disease, or heart blocks or sinus bradycardias. And we know pregnancy is a state where people are prone for arrhythmias. And these patients, obviously, for various reasons, pregnancy is at higher risk of having all these comorbidities, and they are prone to develop arrhythmias. And sometimes it could be the first presentation of an arrhythmia, or it could pregnancy itself exaggerate the arrhythmic symptoms for a person who already has an underlying structural or arrhythmia syndrome. But as far as I'm aware, none of these arrhythmic conditions are not an absolute contraindication for pregnancy. However, these patients will require a electrophysiologist, with follow-up with an electrophysiologist. And sometimes we might have to intervene during the pregnancy. Most of the time, we try to manage them medically. Very rarely, if we are to do any intervention or a pacemaker or ICD or an ablation, we will choose second trimester. And moving from that, if you think of arrhythmia with a structurally normal heart, that means they have a normal 2D echogram. If you want to do a cardiac MRI, you might find subtle changes, but there are no gross abnormalities. We think they are purely electrical. If you take some examples, inappropriate sinus tachycardia, AVNRT, or accessory pathways, certain focal atrial tachyarrhythmia, most of the time out for tract PVCs and other types of PVC. Generally, they have a very benign course, having excellent prognosis. However, remember that certain arrhythmias, they can cause LV impairment in the future. Generally, sudden cardiac risk is very rare. And the point I need to highlight is that most of these arrhythmias are easily fixable with catheter ablation. And moving from that, this is something that we need to take very seriously. And sudden cardiac death in younger age is a tragic. And every now and then if you follow the news, you might hear that young people found dead and under unusual circumstances. And most of the time, these are arrhythmic deaths. And these are most of the time, these happens due to pulses, VT or VF, but very rarely it can happen with complete heart block or SVT in the presence of already existing LV dysfunction. As you can see, considering age 16 to 40, you would see that the risk of dying, the incidence is 2 per 100,000 people, roughly around about the same age. So if we take what condition that could cause these type of tragic situations, Brugada syndrome, congenital long QT syndrome, early repolarization syndrome, and here's the list, and you can see almost all these conditions are inherited, and as a blanket term, we might call them channelopathies. And this progressive cardiac conduction system disease is obviously we see rarely in young people that they develop sinus bradycardias and AV nodal disease without having any other structural abnormality. WPW syndrome is not a channelopathy, however, it can cause sudden cardiac death. Don't forget hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy. And this is MVP and malignant mitral syndrome is something new. And we thought MVP is a benign condition, but now there are evidence piling up to say that certain MVPs could actually generate malignant arrhythmia and lead into sudden cardiac death. Now, there's a few ECGs you could appreciate the long QT in the first ECG, and the right top ECG shows the Brugada changes. The left bottom ECG shows early repolarization, and right bottom ECG shows short QTs. And as we know, congenital people with congenital heart disease, now they are surviving into adulthood and they develop various kind of arrhythmias. And if we take all kinds of valvular heart disease and cardiomyopathies, alcoholic cardiomyopathies, secondary heart disease due to chronic airway disease, and now we see lot of people who develop myocardial infarction in their younger age, and that leaves a damaged myocardium, scarred myocardium, and they are prone for arrhythmias. So if we take as whole, we can see that arrhythmia is obviously a significant burden to our health system, and it is more so when young people develop arrhythmia. So arrhythmia leads to repeated hospital admissions, and it could be manifested underlying cardiac disease. It could lead to decompensated heart conditions, and arrhythmia sometimes cause sudden cardiac deaths. And remember that arrhythmias runs in family. So what are the management implications? So the first we need to highlight is that we have to establish the rhythm ECG correlation or symptoms ECG correlation, and then we have to make sure that there's no structural or electrical abnormality. And thirdly, we need to reduce or eliminate the probability of having another episode. And fourthly, we need to reduce or eliminate the probability of dying suddenly as a result of the arrhythmia kicks in. And we have to manage them in such a way that it will not limit the ability to live a normal life that includes sports participation, recreational activity, and undergoing pregnancy. So what are our management goals in the acute setup? If a person presented with abnormal rhythms, we have to restore the sinus rhythm for a meaningful duration to alleviate symptoms. And if the patient is hemodynamically unstable, we have to follow the resuscitation guidelines. You could do the cardioversion or defibrillation or transcutaneous or transvenous pacing for a bradyarrhythmia. If the rhythm is stable, we have to get this idea that we need to restore. It could be a VT, it could be an SVT, it could be atrial fibrillation. We have to restore the normal rhythm by the least invasive method. That includes pharmacological treatment, anti-tachycardia pacing, DC cardioversion, and left stellate ganglion block in case of having recurrent VTs. And we have to make sure that we correct the underlying biochemical hormonal abnormalities or remove toxin, and we may have to unload the heart, control the volume overload status. And if we take heart rhythm issues and looking at the long-term management, here are our goals. We have to offer them a tachycardia suppressive treatment that includes pharmacotherapy, and we have to actively evaluate them for the suitability for catheter ablations. And we have to consider offering them cardiac electronic implantable devices that includes bradycardia and tachycardia. Don't forget about the anticoagulation, and we have to make sure that we treat the underlying condition in order to minimize the cardiac damage. So comprehensive history taking is very important, and these slides are self-explanatory. And it's very important to, if you are lucky, you have the ECG with you. Sometimes they presented sometime after having the symptoms, and the ECG at the time you do may not have obvious abnormalities, but you need to read between lines and look ECG carefully and methodically in order to find these type of abnormalities. Make sure that your patients get the necessary imaging in the form of echocardiogram or cardiac MRI scans or CT scans, and that will enhance our understanding, and that will enhance our way of treating these patients. And make sure that genetic and family screen should be offered to these patients as well. So why do we need to sort an electrophysiologist? Because each individual patient with rhythm issues require very personalized evaluation and treatment. And remember that we live in an era where personalized practice of medicine is now becoming the norm. So As an electrophysiologist, we can offer you comprehensive heart rhythm evaluation for your patients, and we can provide catheter ablations and necessary pharmacotherapy, and we can assess this patient for the risk of sudden cardiac death, and we can offer various type of cardiac electronic implantment device therapy, and if it come to that, we can give you inputs to manage special situations such as sports participation, pregnancy, and family screening. So electrophysiological study is a study that is a minimally invasive procedure using catheter introduced through either veins or arteries to record the electrical activity from within the heart. And that is what we do in the cath lab. So electrophysiological study help us to determine the nature of the tachycardia in its pathophysiological nature, and thereby helping us to treat these patients. And this is what we do. We put catheters through the groin, and catheters are placed at various locations inside the heart, gathering information. We can test the cardiac electrical activity, the system, and we can find the abnormal areas, abnormal connections, and then we can treat. As you can see, this is an important slide. I want to highlight that ablations offer very promising results. If you take focal atrial tachyarrhythmia, atrial flutters, AVNRT, all these tachycardias basically can be completely cured by doing an ablation. So the hallmark of this presentation to give you an idea that your patients require more than giving a beta blocker or a calcium channel blocker or amiodarone. And heart rhythm management, as in electrophysiology, we can offer a lots of treatment and inputs to manage your patients and make them feel better and safe. So wrapping up the presentation, in summary, we have arrhythmias in young people could be due to various causes, and most commonly these arrhythmia present as briefly or sustained palpitation or transient loss of consciousness. And very rarely it could be a early manifestation or precursor to that can cause sudden cardiac death in time to come. That is something we have to remember. And arrhythmia in young people means it's not a uniform group. It is a group with heterogeneous subgroups in it. And focus history tracking is the key, and do a thorough examination and plan your investigations. And careful assessment of both tachycardia and non-tachycardia is very important. And it's important for us to establish the symptom ECG correlation. It's sometimes long-term and ambulatory rhythm monitoring is required. Cardiac structural assessment can be done with MRI and 2D echo. And most arrhythmias now can be treated effectively with minimal invasive approach. And we can offer you cardiac implantable devices and catheter ablations for these patients, and in order to reduce the symptoms burden, and at best we can cure them and prevent them dying suddenly and improve quality of life. Thank you for listening.
Thank you very much, Dr. Kirti Divulheva. That's a very comprehensive overview of a common topic. And we'll move to the next topic. Our next speaker is Dr. Vajra Senaratne. He is known to all of us. He doesn't need any introduction. He is going to talk to us about interventional cardiology, current and future perspectives of Sri Lanka. Over to Dr. Vajra Senaratne.
Good morning. First of all, I must thank the President and the Council members of All Medical Association for making me a part of this important clinical meeting. The topic today is Interventional Cardiology, the current and future perspectives in Sri Lanka. You all know, when you go back to the history about 3 decades ago, Our cardiology care in Sri Lanka was in a very primitive state. The first cath lab was introduced in 1989, and afterwards, for the last 3 decades, there have been so many cath labs started Sri Lanka at various places. For instance, Galle, Kandy, Kurunegala, Anuradhapura, Jaffna, Polonnaruwa, and recently at Kaluthar. With this, the cardiac care was dramatically improved in Sri Lanka, particularly for the chronic patients. I'm going to discuss on the following headings: the therapeutic strategies in cardiovascular interventions. First is intervention management of chronic coronary syndromes, which is earlier told as stable angina, and then acute coronary syndromes. And management of complex coronary cases such as left main disease, undilatable and calcified lesions, chronic total occlusions, CTOs, and novel techniques used for improved outcomes in coronary interventions, such as coronary physiology and coronary imaging. And lastly, the structural and valve interventions, valvular heart disease and congenital heart disease interventions. First, I would like to discuss the most common problem, the coronary disease. That is 2 categories we call chronic coronary syndrome and the acute coronary syndrome. You know, the coronary plaque due to atherosclerosis gradually develop over a period of time, and when it becomes about 70% or so narrowed, you can develop angina. And then when there's a plaque rupture, you can end up with the acute coronary syndrome. So basically, chronic coronary syndrome and acute coronary syndrome are part of the same process, which is a dynamic process. Sometimes chronic coronary syndrome becomes acute coronary syndrome due to plaque rupture. And then when the plaque is settled after a few months or so, then it becomes chronic coronary syndromes. So management depends on which situation with the patient, the chronic coronary syndrome or acute coronary syndrome. Usually the management was angina was optimal medical therapy with lifestyle modification. With the introduction of cath labs, the interventional therapy became a major part of management of coronary syndromes. Most of the time, we do angiograms, invasive angiogram in patients with symptomatic patients who are high-risk patients, or when you try with medical management with failed optimal medical therapy. And all these patients are basically treated with statins, antiplatelets, beta blockers, and ACE inhibitors, etc. And there's a study which want to find out in stable patients with at least moderate ischemia, does catheterization and revascularization improve outcomes when added to OMT therapy? That is called ischemia trial. They randomized study for the invasive strategy with optimal medical therapy with conservative strategy with optimal medical therapy alone. Of course, they excluded high-risk patients like left main disease more than 50%, ejection fraction less than 35%, EGFR less than 30%, acute coronary syndrome within 2 months, and valvular disease. So all the risk factors were included in this study. But the primary outcomes such as cardiovascular death, MI hospitalization, and for unstable angina and heart failure, all these outcomes, there was no big difference over a 5-year period of time with conservative versus invasive therapy. And particularly when you look at all cause, there was no signal at all. So what is the difference between the invasive versus medical therapy? That was the conclusion ischemia trial. Patient with stable coronary disease with moderate to severe ischemia had significant durable improvements in angina control and quality of life with an invasive strategy if they had angina. In patients without angina, an invasive strategy led to minimal symptom or quality of life benefits as compared to conservative. That means most of the patients stable coronary disease. If there are no symptoms, the benefit of invasive therapy has no major value. But you remember, the quality of life is very important. The young working person who has angina, the quality of life is deteriorated and they can't perform. So death is not only matters, the quality of life is important. So invasive therapy helps them a lot to keep good quality of life with angina-free status. So you have to remember that angina baseline invasive strategy is better. There's no angiogram baseline, no difference between invasive and conservative therapy. That's the basic conclusion from this trial. I'll move to the acute coronary syndrome. There are these patients, as I told you, they develop after coronary plaque rupture, develop thrombus, and gradually occlusive vessel. The patient may have typical signs of angina. There's tightening, severe chest pain, which lasts for half an hour or more, which is pain over transfer to neck, jaws, and back of the chest. And they can ECG might show ST depression, or ST elevation. There is ST elevation with acute ST elevation in mind. So then you do troponin. If the troponins are negative, pain is rather atypical. Let me, of course, rule out MI. But the patients who have got suggestive pain, positive ECG changes with positive troponin, depending on the ST elevation or depression, label as acute ST elevation MI or non-ST elevation MI. So management depends on whether there's ST elevation or not. So look at non-ST elevation myocardial infarction and when to intervene. This is by EAC guideline 2020. This clearly shows there are three categories of patients depending on the clinical the risk category. There's a category score we have called gray score, which you can calculate and decide about the high risk patient. Patients particularly with high risk are the hemodynamic instability, cardiac shock, recurrent refractory chest pain, life-threatening arrhythmias, mechanical complication, and ST segment more than 1 millimeter over more than over 6 leads. And these patients are high-risk patients. If you don't intervene, they may end up with disaster. Therefore, those patients should have invasive management within 2 hours. So those are very high-risk patients. Another category of high risk, which you get with gray score more than 140. And those patients also have a non-STEMI, dynamic ECG changes, or maybe resultant cardiac arrest. And gray score more than 140, those are high-risk patients. They should be taken to cath lab within 24 hours. The other group is a low-risk patient where you don't have these high-risk features. Those could be managed in a ward and necessary like stress test, ECG, CT, whatever it is, and then you can manage them. You can take your time and manage. So most important thing, assess the risk of this patient and act accordingly. The next, gray score, you have so many parameters to decide: the age, heart rhythm, systolic pressure, heart failure, future lip glass, creatinine, accessible deviation, so on. And if they have gray score more than 150, is considered high risk and to be done within 24 hours. Then I move to acute ST elevation MI. These are the patients, as I told you, get severe chest pain, ongoing chest pain. And the patient, if they come to the PCI center, those patients should be done according to the EAC guideline within 10 minutes, and ST elevation, they should directly direct to the cath lab for primary PCI. You should not go, they should bypass the CCU and all that, directly go to cath lab. Patient comes to the non-PCI hospital, you have to decide what is better, with the thrombolytic therapy or primary PCI. But if you assess the patient's time to reperfuse the artery is more than 120 minutes, they should be, as soon as they should be given thrombolysis therapy and then manage accordingly. So if you feel that you could open up this artery by transferring to cath center, within 120 minutes, the patient should be transferred to the cath center for primary PCI. Now, all this factors depend on the time. If you get a patient within 3 hours, a primary PCI and primary both are very good study because the thrombus burden is less. When fibrinolysis is also good. But what happens is fibrinolysis only you clear the thrombus, but the plaque remains there, so you might have to re-intervene. But patient comes after 3 to 12 hours period. Still, primary PCI is the best management strategy. But if you can't transfer the patient within 120 minutes, then you should be given thrombolysis. What happens if the patient comes late, 12 to 48 hours? Essentially, there would be thrombolysis management, only primary PCI. If the patient, even after 48 hours, if the patient has ongoing chest pain, hemodynamic stability, or arrhythmia, they should be taken for primary PCI. But if the patient is stable, after 48 hours, routine PCI is contraindicated. That is 3A. That is, by doing that, you may do more harm than good to the patient. Therefore, after 48 hours, you should not attempt unless the patient is unstable. I would like to show you a case I've done, acute constitutional multivessel disease. This is a patient, 64 years old man with acute ST elevation MI with ongoing chest pain. And he has family history, but no diabetes, hypertension, or smoking. His hemodynamics is stable, pressures were normal, heart pulse rate is about 48. And you look at the angiogram, you see he has a small circumflex and a huge bifurcating ramus, which has about 90% lesion. And second picture, you can see the LAD is totally occluded at the origin. You can see from this pointer, you is totally occluded. And again, you can see the right coronary artery has critical narrowing in the mid-segment. So the management, this is a 64-year-old man with no diabetes, acute ST elevation MI with ongoing chest pain, critical three-vessel disease with acute LAD occlusion or at the LAD osteum. What are the treatment? Obviously, medical management for health. So you could do either urgent CBG or primary PCI. You know, urgent CBG, it takes time to arrange the patient. It might take few hours. By that time, there should be myocardial damage. So it is not the best option for such patient. Therefore, we should try and open up these arteries with primary PCI. See, this is what we have done. We have put the guiding catheter, pass a wire through the lesion, cross the lesion, and just passing the wire, you can see the vessel is open. The LAD is fully open. That is the most important artery in the system. Then what you do is you do balloon, and then you can see flow is much better. Then you do the stenting, and see the LAD is fully open nicely with TB3 flow. Now we have to do something for the ramus. We are putting another stent to the, it's called a bifurcation stent. We call tap technique. I don't have to liberate on this at the moment, but there's a technique we used routinely for this sort of bifurcation. And we do trap stent into ramus while keeping the balloon in a lady. And you see the result. So this is before PCI. This is after PCI. So we have established flow in LAD, which is totally occluded, and ramus within half an hour or so. So then the patient is stable. Now what are we going to do the right coronary artery? We don't have to do all this in the same time. We can wait till the patient is stabilized. So we form it about after 48 hours later, we step to the right coronary artery, and that is a result. So this is a patient with acute anterior MI with severe three-vessel disease. What is the evidence to do all this at one sitting? This is the latest trial, complete revascularization in ST MI. That trial shows that published in NEJM October 19. That shows they studied 4,000 patients. The culprit only, culprit only, or multivessel disintervention, and that clearly showed culprit only versus complete revascularization has a significant benefit with regard to cardiovascular death and MI. The p-value is 0.004, very significant. So acute estimation MI, you have to do the complete revascularization, not necessarily at the very outset. You may do it before discharge or maybe a little later, but complete revascularization definitely beneficial than handling all the culprit lesion. And what to do when you have a cardiogenic shock with acute MI? The latest guideline says if you have a cardiac shock, you have to handle only the culprit vessel. If you do other vessels, the risks are higher. This is a 2018 ESC guideline that clearly shows routine revascularization non-infarctual lesions should be considered in all patients with multivessel disease before hospital discharge. That is level A, 2A level evidence. And cardiogenic patient doing all three vessels is contraindicated because it carries higher mortality. Now I would like to show a patient who has come a little late. There's a large thrombus. The left system is totally normal. You see the right coronary artery has total block at the distal RCA. What we do with there's thrombus, we do a thing called use aspirate catheter. You can see the wire cross the lesion. Then you used, I don't know, you can see this is the one called the dot, that is called export catheter. You try to aspirate the clot with the export catheter. And after aspiration, you can see the result is better, but you can see large thrombus burden sitting in the distal right coronary artery. What you do is, this is an exceptional case which cannot be, not, there should be done only by experienced person. I deep throated the right coronary artery catheter to the clot lesion and aspirate the clot. You can see the amount of clot we aspirate, large thrombus burden. And after that, you put the stent, and then you can see the result. Wonderful result, superb result, almost normal after removing the clot and stent. And I will like to move to complex coronary interventions. Left main coronary artery. The left main coronary artery was basically a surgeon's territory all these years. We started, if you look at the guideline, you see left main disease with low test score. That is the way you can assess the coronary artery structure. And if syntax score is less than 22, the class 1A, both for surgery and PCI. So left main is not only surgery, it has class 1A indication for interventions with the syntax score less than 22. The patient between 22 to 32, it is two-way indication. Surgery is still better there, but still PCI has a place two-way. But if the syntax score is more than 30, it's essentially surgical because PCI is contraindicated in this situation. So you have to decide which patient you are going to do. You have to evaluate the patient before embarking on intervention. This is a patient, I did the first case done in Sri Lanka's left main. I did in 2003 or so. This is a 35-year-old lady presented with class 3 angina with normal LV function. You see the angiogram, I don't know, you can notice there's a critical ostial narrowing, almost 99% ostial narrowing. Those days it was essentially surgical patient. Now see what we have done. We have put the guiding catheter, and you can see the degree of problem. We have a pass of wire, and you balloon the left main, and after dilatation you can see it's better. Next you position the stent, and then you deploy the stent. And now post dilatation you can see wonderful results. So it's become day to day. I mean, you are doing a lot of more complex lesions now, not ostial mid-shaft bifurcation lesion. That is part and parcel of our day-to-day practice, and that is with evidence from ESC and European ACC guidelines. The rote ablation, which is a complex coronary intervention when there's calcified coronary artery. You know, calcium is the enemy of the intervention. But when a patient like this comes, this is a patient who has got totally normal left system with right coronary two critical lesions with heavy calcification. But my colleagues attempted to cross, and he could not pass the balloon. That's why he referred the patient to me for rote ablation. So what happened? This calcium spicules jutting into the lumen. Therefore, we can't pass balloons or stent. Therefore, if you don't have rota, you have to give up the procedure or send the patient for surgery. See, this is the gadget. You have a diamond rota blade. There's a burr has a diamond cutter, and it cuts clearly cuts to the calcium plaque and make it quite smooth. You can see this from picture. You can see the rotablator. We use picking movements and gradually clear the lesion. You can see nicely it is clearing the calcium in the vessel. And then what we do is we put the stent. You can see the distal stent being implanted, the proximal stent. Now the whole vessel. Now you can see the difference. The lesions we were unable to cross with the balloon. Now we are stented with wonderful result thanks to the rotablator machine. I'd like to put the complex coronary intervention, other one, chronic total occlusion. Somebody might ask why do you want to open up the coronary arteries when the total occluded patient is living normally. But in fact, you don't just open up artery unless you demonstrate the viability and symptoms. If the PET scan or the ischemia burden is more than 10%, is considered high risk, therefore you have to open up. Is there evidence? Yes. The EuroCTO trial showed great improvement of angina and quality of life with successful CTO interventions. And there are 25 session studies showed that a median follow-up of 3 years, successful CTO PCI was associated with 1, improved clinical outcomes in comparison with failed revascularization, including overall survival, angina burden, and requirement for CMS. And ideally needs demonstration of viability by non-invasive tests, because you can't just open up close till you open out, till you demonstrate non-viability. However, it's tedious process, may carry higher risk. So you have to spend a lot of time, high radiation and contrast. So this will be done by a very experienced person. This is usually we do anticipate, but retrograde canalization not done. Actually, this is the actually first or second case done in here, Sri Lanka. Retrograde retrograde tracking. You can see right coronary artery. There's a critical narrowing. It's totally up to right coronary artery. You take dual injection, but both sides, right and left, both. Then you can see a long segment is missing. So it's not fair to send only surgeon for bypass just to revascular right coronary artery. Therefore, CTO opening is very important. So we tried antegradely from the normal way it didn't cross. This is the way you go. You try to integrate, it failed. Then you go through this collateral supply and enter and try to go through the reverse way. And this is a angio showing. You can see the nice collaterals connected to the retrograde filling of the distal RCA. What we do is, you can see we have passed a wire directly with the help of microcatheter, go through the collaterals trying to enter right ostia. Here you can see the wire almost enter in the right coronary artery. So there's a nice loop. Now we can go through the, again, right coronary artery this way and balloon it and deploy the stent, first stent, and deploy the second stent. And you can see the result after PCI. So this sort of patient, if they need, as I said, for bypass, which is not fair. So I think we should be able to open up by way of either antegrade or retrograde crossing. I would like to discuss then move to the next topic, novel techniques for improved outcomes in coronary intervention. There's physiological measurement such as FFR and IFR and coronary imaging. For physiology, FFR is fractional flow reserve. The FFR considered the gold standard measure to evaluate the clinical significance of lesion. And there are 2 trials, FAME 1 and 2, that have shown that patients with stable angina, when the FFR is this, for instance, how do you calculate? If you assume the pressure is at the altitude is 100, if drops to 80 or less, then it's not significant. But if it drops to 79 or more, that indicates that's a clinically significant lesion which should be revascularized. And now, FAME trial also showed that patients with multivessel disease, FFR guided PCI is superior to angiography guided PCI, because you won't make any mistakes by doing that. You only revascularize the only necessary vessel, not unnecessary vessels. If there is evidence here, there's class 1 evidence of using FFR to do these procedures, then either multivessel 2A and other, anyhow, there's one indication using MFR. This is a patient who has got critical narrowing of right coronary artery plus tight lesion in a middle lady and proximal big diameter. So if you don't have FFR of this, I would have stated RCA, LAD, and D1 all 3 vessels if you go by angiography. But here we have done FFR. You can see right from the tight lesion. FFR has come to 73. That is highly significant. We have done the PCI to RCA. You can see post-op PFFR come up to 90, that's almost normal. So that gives a very clear picture that we have done the correct job. Now you move to the other side. This is the vessel. You have the put FFR wire to the diagonal. You can see the FFR value is 81. So that is not very significant. So you don't have to do a stent. You can manage the diagonal with medical management. Now you move to the LAD. You can see LAD FFR is 72. And we did the PCI and it has come to 94. So this gives a very good scientific idea as to how you handle how many vessels to be stented. Then you minimize the stenting. Sometimes the patient you send for 3 vessel disease for bypass. If you do FFR, it might become a single vessel disease. Therefore, these tools are there to optimize the outcomes. Then I like to move to the coronary imaging, intravascular ultrasound, IVUS. This is the IVUS catheter. You pass through the coronary guide wire. You can very clearly see this picture. You can evaluate the length of the lesion, the quality of the lesion, the plaque. You can the disease vessel. You can see the plaques, fluid in the narrow lumen, and you can see there are the thrombus. When there are flaps causing a false lumen and a true lumen dissection, and you can see the amount of calcification, this hypogogenic. So this is very useful in managing this patient. You can get a very accurate sizing of the vessel. You should know how to, whether you have the correct lumen or not, or whether you have a lot of calcium, then you know what equipments to use rather than just try to balloon this. You can't open this with balloons. And I would like to show this picture. This is a live picture showing normal anatomy. Now, when we turn toward the left main, you can see the plaques appearing here gradually. And coming down, you see the very, very narrowed vessel with plaques. So we know exactly what the amount of narrowing, and you can measure the length. So by using IVUS, you can really assess the patient. And particularly if you're dealing with left main, IVUS is very important because you can precisely position the stent and also get the optimum dilatation by using IVUS. The structural valvular interventions, I don't have to elaborate this. VSD one we have done some time ago. We can nicely close the VSD. You can see the VSD has closed completely. And ASD also we nicely put the two S device. And once you release the device, it is fully closed. So these have been done large numbers in Sri Lanka now. We do most of the ASDs, so still secondary ASDs, and muscular and peripheral VSDs with device closures. And the last topic I'm going to discuss is valvular interventions. The transcatheter aortic valve implantation, TAVI, is very popular at the moment. Unfortunately, Sri Lanka, because of course we can't do many cases, these are really expensive at the moment. But there have been few cases done in Sri Lanka. The surgical aortic valve replacement versus TAVI. You see the patient with lower risk, young age, and patient having, say, sort of suspected endocarditis. Whether you have access site problems or coextensive valve disease, you have to send the patient for surgical valve replacement. But the patient with higher surgical risk, such as elderly patients, the previous cardiac surgery, or severely frail patient, you should attempt TAVI, that is percutaneous valve intervention. So, surgical AV, I recommend a younger patient who are low risk for surgery with low uroscope. This is ESC 2021 1B indication. TAVI is recommended in all the patients more than 75 years or those in higher risk. Uroscope more than 8 or unsuitable for surgery, that is 1A. So this is a TAVI 1A indication. So with time, I think we should be able to do more and more cases. And their future directions. The intervention of cardiology is a rapidly developing field. The percutaneous structural intervention will be foremost in the pipeline, such as mitral replacement. These are all percutaneous. Tricuspid replacement, pulmonary valve implantation, and AL appendage closure. Vascular intervention, including venous intervention, is coming in a big way. The cost effectiveness with time will make this available to Sri Lanka as well. So we have to wait till the cost comes down. And the future of cardiovascular care will be transformed by advances in digital health technology, and mobile devices. Thank you very much.
Thank you very much, Dr. Resynchronization. We need the third speaker. Dr. W. Santaraj will be speaking to us on treatment of chronic heart failure. Dr. Santaraj is a senior cardiologist. May we move on to the third speaker, senior cardiologist, Dr. Santaraj. He will speak to us on treatment of chronic heart failure.
Thank you. First, I thank the Gall Medical Society for inviting me to give this lecture on treatment of chronic heart failure. Heart failure is a highly prevalent condition. Over 60 million people worldwide have heart failure. It's associated with high rates of morbidity and mortality. It poses a significant strain on the healthcare system. And it's the number one reason for admission to hospitals over 60 years of old. Heart failure can be divided into three groups. Those are heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. All three groups will have signs and symptoms of heart failure. And for the reduced ejection fraction group, the ejection fraction should be less than 40%. And the mildly reduced ejection fraction group, 41 to 49%. And the preserved ejection fraction, of course, the ejection fraction will be more than 50% by echocardiogram or other imaging modalities assessment. The preserved ejection fraction group should also have objective evidence of diastolic dysfunction, and also you should be able to demonstrate by echocardiographically or invasive method raised left ventricular filling pressures, including raised natriuretic peptides. There are several causes of heart failure, but coronary artery disease, valvular disease, hypertension, and dilated cardiomyopathies are the common problems we face in clinical practice. Clinical features: dyspnea, swelling of body or legs, loss of appetite, lethargy. Symptoms can be acute or chronic onset. Past history of cardiac illness may or may not be present. Edema, dyspnea, raised JVP, cardiomegaly, third heart sound, gallop rhythm, basal crackles, all should be looked for when you are assessing a patient clinically with heart failure. So this is the algorithm. In a suspected heart failure with symptoms and signs suggestive of heart failure, if they have an abnormal ECG, then of course you can go in two ways. That is, you can straight away go and do a BNP level, natriuretic peptide level, or go for an echocardiogram. In our country, of course, getting an echocardiography is done is easier than do a natriuretic peptide because it's not widely available. So the echocardiography is the mode to go in our setup. If the echocardiography shows abnormal findings, then you have to categorize these patients into whether they falls into a reduced ejection fraction, mildly reduced ejection fraction, or a preserved ejection fraction group. And depending on that, then you can go for the etiology and then commencement of the treatment. If there is no echocardiographic findings and the natriuretic peptides are normal, the heart failure is very unlikely to consider other diagnoses. Assessment, all the patients with heart failure should be assessed hemodynamically, the blood pressure, then pulse, fluid balance, renal functions, weight, full blood count, ECG, chest X-ray, and any other appropriate investigation like thyroid function and cardiac enzymes should be done. Objective of treating heart failure patient include relief of symptom, look for precipitating factors, improve long-term prognosis, identifying and treating the cause of heart failure, and management of end-stage heart failure. Common precipitating factors are anemia, infection, medications like non-steroidal anti-inflammatory drugs, arrhythmia, excessive salt consumption, ischemic heart disease, acute coronary syndrome, endocrine abnormalities. If you find any of those should be treated promptly to treat the underlying heart failure. The drug treatment wise, the medications can be divided into two broad categories. The first group is the medication that can reduce the chance of mortality in heart failure with reduced ejection fraction patients. The group 1 include the AC inhibitors, ARB blockers, and the new ARNI group, that is an angiotensin receptor neprilysin inhibitor group. The only drug available is sacubitril valsartan combination. And the group 2 is the beta blockers, carvedilol, bisoprolol, metoprolol, or nebivolol are approved for use in heart failure patients. The group 3 is a mineralocorticoid receptor antagonist, spironolactone, or eplerenol. Group 4 is the new SGLT2 inhibitors, which are used for treatment of diabetes mellitus, now approved to use in heart failure patients with or without diabetes. The empagliflozin and dapagliflozin can be used in that group. The medication for symptomatic relief are diuretics. You can use either furosemide, bumetanide type of diuretics. Those are loop diuretics, vasodilators, or oral inotropes like digoxin. The heart rate lowering agents like ivabradine can be useful in patients who have tachycardia despite proper beta blockade. Diuretics are excellent medications for relieving symptoms and edema. Doses should be titrated according to the individual need. IV loop diuretics can be helpful in patients with severe heart failure and those who have gut edema and absorption problems. Diuretic should be reduced when the symptoms and the signs of heart failure subside and the patient become euvolemic. That's the best time to start the AC inhibitors and increase the doses of AC inhibitors. Loop and thiazide diuretics can never be shown to improve the long-term prognosis of heart failure. In refractory heart failure, you can use combination of diuretics, a loop, and a thiazide type of diuretic to achieve the diuresis. When you take the AC inhibitors and ARB blockers, our group 1 drugs, the studies and the clinical trials have shown these drugs are very effective in treating heart failure and the risk reduction. When you are comparing with the placebo, AC inhibitors showed about 30 to 40% risk reduction in several studies. You can see there are several studies tabulated here. And similarly, few studies have shown with ARB blockers 30% risk reduction, and the new ARNIs, that is the angiotensin receptor and neprilysin inhibitor group, has a 20% risk reduction in addition to what you get with ACE inhibitors or ARB blockade in heart failure. That's the reason of these medication has become a first-line drug in treatment of heart failure. The Paradigm heart failure trial is the one showed that when you're comparing with ARNI with ACE inhibitor enalapril, there is almost a 20% risk reduction on top of the advantages you get with ACE inhibitor enalapril. Beta blockade, there are three big trials: the Copernicus with carvedilol, Merit FM with etoprolol, and the CBs with bisoprolol, all shown about 30% risk reduction when you use in heart failure patients. The similar way, the mineralocorticoid antagonists, spironolactone and eplerenone showed about 15 to 35% risk reduction in RAILS, FSS, and emphasis trials in different settings. So when you combine these drugs, you can get, rather than using individually, when you combine these drugs, you get additive effect in heart failure. You can see either you can combine ACE inhibitor beta blocker MRA or ARNI beta blocker MRA and get maximum benefits for your patients. The SHIFT trial, which has been shown here, is done with the ivabradine, the heart rate lowering agent. This is used in patients with maximally treated heart failure, patient with all medication mentioned above, and those who are on maximum tolerable dose of beta blockers. Still, if their heart rate is more than 70, then they use ivabradine, and they have shown cardiovascular mortality or heart failure hospitalization is reduced 14 to 17% in these patients. So if any person who have on a beta blockade, if you can't achieve a heart rate of 70, then you can add these medications. With the FDA requirement of all new anti-diabetic agents should undergo a cardiovascular risk trial, they have performed these cardiovascular risk trials in the new anti-diabetic agents. So the two agents, dapagliflozin, empagliflozin, there are more new agents now. And these were studied for cardiovascular risk in their original trials. And interestingly, they noted the cardiovascular death and hospitalization for heart failure, first hospitalization for heart failure, and renal composite endpoint, these three were significantly reduced in patients who were receiving these agents. Hospitalization heart failure is almost 25% reduced in the original trials. That led to the trials on heart failure with these drugs, those who are with diabetes and without diabetes. And those are the two major trials, DAPA heart failure trial and Emperor reduced trial. You can see cardiovascular death or hospitalization for heart failure is almost reduced to 25%. And the first hospitalization heart failure again, about 30 to 30% reduction. And you can see the renal composite endpoint. The renal problems are common in heart failure patients. That is reduced to almost 30 to 50%. So it's very advantageous medications using to use in heart failure patients in clinical settings. And you can see in the Emperor reduced trial, the benefits started occurring in the day 12 of starting the medication, and it reached the significant level in day 34. So it's almost within 1 month, you can get a significant reduction in cardiovascular risk if you use these agents. What are the advantages of using the new heart failure medications, the SGLT2 inhibitors and ARNI? The SGLT2 inhibitors, they decrease the risk of hyperkalemia. So the most of the heart failure medications like ACE inhibitors, ARB blockers, mineralocorticoid receptor antagonists, all increase the risk of potassium. So when comparing, combination with this medication, it decreases the hyperkalemia. That is one of the important action of SGLT2 inhibitors. It also slows the progression of renal dysfunction. It has been shown clearly in the clinical trials. And so you can increase the ACE inhibitors, ARB blockers, ANI, or MRA whenever it's needed. It has minimum effect on heart blood pressure and symptomatic hypotension in patients with heart failure. When you take the ANI, the angiotensin receptor norepinephrine inhibitor, when you compare with ACE inhibitors and ARB blockers, it causes less hyperkalemia. So that's the advantage of this drug. In addition to the additional benefit it has above ACE inhibitor and ARB blockers. So what is the recent guidelines say? The ACE inhibitors, beta blockers, mineralocorticoid receptor antibodies, SGLT2 inhibitors are all class 1A indication for treatment of heart failure. Sacubitril valsartan, the ARNI, is placed in 1B because it has only one clinical trial which has shown clinical benefits. Other pharmacological treatment, as I mentioned, the diuretics could be used in congested patients and to improve the heart symptoms, improve the exercise capacity, and reduce the heart failure hospitalization. The ARB blockers are shifted into a 1B category. That is because ACE inhibitors are the first line medication to use in heart failure patients. But if the patient is ACE inhibitor intolerance, then of course, ARNI is the best alternative because it has an ARB blocker and neprilysin inhibitor, and it is more advantageous than the using ARB blocker for replacement. But this drug is not widely available in Sri Lanka, but in future, I think when ACE inhibitors are intolerant in patients with heart failure, the ARNI will become the recommended drug. Other pharmacological agents, the ivabradine, as I told you earlier, you can use if the heart rate is more than 70, despite the treatment with evidence-based treatment with beta blocker. Ivabradine also can be used in patients with contraindication to use beta blockers, like in bronchial asthma. When you come to heart failure with mildly reduced ejection fraction, the clinical trials are very, very less in, there are no clinical trials performed. There are several clinical trials performed in this group, but the treatment-wise, these patients should be treated as a patient with reduced ejection fraction patient. That's what the diuretics, ACE inhibitors, ARB blockers, beta blockers, MRA, and ARNI can be used, but the level of evidence is not very good because there are not very many trials to demonstrate the advantage. So when you use medication, if the patients are very symptomatic, you can consider device therapy. This is called cardiac resynchronization therapy. Who are the people who are eligible to get a cardiac resynchronization therapy? They should be in sinus rhythm. Those who have wide QRS complex, likely left bundle branch block, and severe systolic dysfunction, like ejection fraction less than 35%, and persistent moderate to severe heart failure despite optimal medical therapy. And it has been shown that you can get about another 30% risk reduction if you use cardiac resynchronization therapy. So in summary, if you take the chronic heart failure treatment, the ACE inhibitors, ARNI, beta blockers, MRA, and SGLT2 inhibitors are the 4 cornerstones of treatment of heart failure in reduced ejection fraction. These drugs should be started early as possible when the patient hospitalized or in an outpatient setup. And if the patient is congested, you have to start with the diuretics. Once they become evolemic, you must start these drugs concurrently. I think the best is to start with the SGLT2 inhibitors because they have the diuretic action, and you can come down on the diuretic dose when you start SGLT inhibitors with diuretic. Then you can start on ACE inhibitors, beta blockers, and MRA on consequently. And associated conditions you have to be deal with, that is the patient, if the patient is symptomatic despite the medical treatment, if they have white QRS complex, you can consider the cardiac resynchronization therapy. And also if they have ischemic etiology and if they are prone to get arrhythmias or life-threatening arrhythmias, then of course you have to consider intracardiac defibrillator. Associated conditions like atrial fibrillation, the patient should be prescribed anticoagulation. And to control the heart rate, you can use digoxin, beta blockers, or if atrial fibrillation is a real problem in treating heart failure because of the AV synchronicity, you can use pulmonary venous isolation to get rid of atrial fibrillation. If they have significant coronary artery disease, you have to consider sending them for coronary artery bypass surgery. And the iron deficiency is fairly common in patients with heart failure, and they should be treated with IV ferric carboxymaltase. If they have aortic stenosis, you have to consider aortic valve replacement, or either by surgically or percutaneously. Mitral regurgitation should be treated with mitral valve repair or mitral valve replacement. If they have heart rate more than 70, you can use ivabradine. In black race, hydralazine and isosobide dinitrate can be considered. And if they are intolerant to both ACE inhibitors and ARNI, then you can use ARB blockers. For advanced heart failure patients, you have to consider using heart transplantation. It is, I think it has been performed in this country, but it's very rarely performed. And if that type of a person, you can consider mechanical circulatory support by devices to bridge the heart failure to do heart transplant. And also improve the quality of life of all the patients, exercise rehabilitation and multi-professional disease management like physiotherapists and nurses should be involved in the management of heart failure. Little bit about heart failure with preserved ejection fraction. They are usually obese, hypertensive, associated with atrial fibrillation. They have pulmonary hypertension. They are usually older, and they have, as I told you earlier, they have a high filling pressures, which can be demonstrated by echocardiography. With all these features, you can diagnose heart failure with preserved ejection fraction. And the treatment-wise, there is nothing much because we don't have a lot of evidence-based medications in treating this condition. The diuretics are the drugs which has been recommended to reduce the symptoms and signs. And you have to screen for the etiologies like cardiovascular comorbidities like hypertension, ischemic heart disease should be treated to reduce these conditions, treat these conditions. As my conclusion, the heart failure should be prevented if it is possible. So there are risk factors for heart failure, the treatment of hypertension, diabetes, lipidemia, and also ischemic heart disease is very important in early stages to reduce future heart failure. That is the stage 1, the high risk for with no symptoms heart failure patient. Those who have structural heart disease without symptoms, again, you must vigorously treat them to prevent future heart failure episodes. The stage 3 is the people who have one episode of heart failure, currently having symptoms of heart failure, should be prescribed all the evidence-based medication I have discussed in this lecture. And the stage D is refractory symptoms, those who are the end-stage heart failure patients. They may need inotrope, frequent hospital administration, and ventricular assisted devices, and may transplantation. If they are not suitable for any of those, then of course, you have to consider hospice treatment and support for this patient as an end of life care. Thank you very much for your, thank you.
Thank you, Dr. Santaraj. We have a few minutes for questions. There have been 3 questions. If you look at the Q&A box, 2 have already been answered by the first speaker. May I direct this question to Dr. Santaraj from Dr. Vasanta Disanayaka. The emperor preserved cardiovascular mortality benefit of heart failure with preserved ejection fraction. What is the cutoff point of EGFR in non-diabetic CKD patients with HFpEF when using SGLT2 inhibitors? I hope the question is clear. It's typed in the Q&A box as well, Dr. Santaraj.
Yeah, I noticed that yeah, I didn't mention anything about the emperor preserved trial that actually it is presented in the recent ESC conference that shows that is the only drug, again, the SGLT2 inhibitor that showed some effect in the heart failure with preserved ejection fraction patients. But anyway, it's not marvelous. The risk reduction is about 10%, you see. So when you compare with the other medications in the heart failure, reduced ejection fraction, the SGLT2 inhibitors cause more than 25% risk reduction. So anyway, these drugs, actually SGLT2 inhibitors will become part of the treatment in patients with heart failure with preserved ejection fraction in future, because those are the ones which have shown in this emperor preserved trial which is effective. Your question is, what is the cutoff point you can prescribe in this medication for patients with renal impairment? Because if you take the clinical trials, actually the emperor reduced trial, the cutoff point for EGFR was almost 20%, 20 ml. So it is very, very reduced ejection, the reduced EGFR. So the EGFR of 20 ml was used in emperor reduced trial. So I think these agents can be used well in patient with kidney, the renal impairment. And when you use these agents, actually what happened is like ACE inhibitors, initially there can be a reduction in the EGFR. But anyway, they get stabilized. When you continue this medication, actually their EGFR improves later. So you can give it a try in all the patients with renal impairment. You can, I think, start this medication in up to, as the trial evidence is there, we can use it from EGFR 20. And yeah, EGFR.
Thank you very much, Dr. Santaraj, for that answer. Then thank you very much from the first speaker as well, who has given detailed answers to the 2 previously asked questions. So in the absence of any further questions, may I take this opportunity to thank all 3 speakers for excellent erudite presentations, which were crystal clear, and for answering the questions also, so that no doubts are left in this area when we finish this session. Together with my co-chairperson, Dr. P.P. Sadanandan, I thank all of you as well as the attendees for participating in this session. Thank you very much.
Thank you. Thank you.